Reach. Okay, we should be starting very soon in next few minutes. Everything is all set. We are also live on YouTube. Am I audible to all of you?
Yes, sir, I can hear you.
Yeah, okay, very good. Thank you. So we should be starting in next few minutes, and Okay, good afternoon to all of you, and we would start our meeting within next 1 minute. This meeting is based on my understanding of the ligamentum flavum, and some of the ideas which you would see and listen today may sound very crazy to you or may sound very out of the way, because these are the things which are not talked about commonly. Now, what we are going to talk about is basically the pathoanatomy and pathophysiology of lumbar canal stenosis, with a very specific reference to ligamentum flavum. And I'm going to clarify most of the concepts which I personally follow in my practice. And I feel that anyone who is able to appreciate the clarity of our ideas and then follow it with the surgical precision should be able to help the patients of lumbar canal stenosis. So if, maybe within a minute or two, I would start my presentation. In the meantime, I'm just trying to point out that lumbar canal stenosis is a very, very common problem, especially with the people who are nowadays seen in our outpatients who are above 65 or so. And they may present, as we talked in the meeting yesterday, day before yesterday, that they may present with cauda equina like symptoms. They may present with pain or numbness or heaviness in the legs on walking or standing. And as I mentioned, that we must be very clear on the symptoms, the assessment of the symptoms, the timing of surgery, understanding of the images, etc. Now, what has happened is there has been a lot of misconception about this ligamentum flavum issue. So I thought that I would clarify this in a very simple, straightforward way so that all of you are able to appreciate why we do our surgery the way we do. So I'm starting my presentation. This is based on my personal understanding of ligamentum flavum. And in the presentation, when you see the slideshow, I'm going to use this pointer, which is like a laser pointer, and I hope you're able to see. So just put in the chat that you're able to see. This is a pointer which at present I'm putting on the word flavum. Are you able to see that? Okay, fine, very good. So we start our presentation and let's see what all we interact and what we learn. And as I said, you may ask your questions on the chat, or you may ask your questions on the at the end of the presentation. So here what I'm doing is, okay, now so let me start. And okay, the first slide which I have shown on the screen is basically is a bony model of L45, and we are looking at this model as we progress from the left to the right, or IJKL. We are looking at a model in a pure sagittal view and then rotate the model towards the front. So the second picture is where we start seeing more of inferior articular process. And then the third picture is where we start seeing more of the pars interarticularis. And then the fourth picture where we start seeing the posterior midline. So I would repeat this, let this be very clear. This is the foramen, which I'm pointing out with the laser pointer. This is seen in pure sagittal view. The second picture is a foramen where we have rotated this first picture more towards the front. The first picture and second picture, the difference is we are able to see the transverse process well, and we see more of the inferior articular process. In the third picture, we see more of pars and more of the spinous process. And in the fourth picture, we are looking at it from behind, or the coronal picture. So we are seeing the midline, and we also see the interlaminar window. The point which I'm trying to bring to your attention is, please remember that we are actually trying to see, or would be seeing, the structures which are in the upper part of the foramen, in the disc level, in the lower part of the foramen, with the pure sagittal view and the pure coronal view. And the point further is that our surgery, which we do through the foramen, is a surgery primarily in the sagittal plane. And the surgery which we do here in the fourth image, that is the interlaminar surgery, is more in the coronal plane, at least the access to the pathology which we have. Now, as we go ahead, this is a sagittal picture, as you can see, and this is supposed to show you the foramen as we see. I'm sure you're able to see my cursor, which is at present on number 1. This is the vertebral body. This is the superior notch. This is the end of the superior notch. This is the ligamentum flavum. This is the superior articular process, SAP. The IAP is the inferior articular process. This is the disc, and this is the inferior notch. Now let us be very clear on one thing. The first important point is the part 1, that is the upper part of the foramen above the disc, that is the blue zone, contains the nerve. The middle part, which is bounded by these two, that is the disc and the SAP and the facet capsule and the ligamentum flavum, is the orange zone. And the lowermost part is the green zone where you have the inferior notch. And we will be going down, for example, in a case where you have a down migrated herniation. Just give me a moment. So here what we are looking at is a picture of the foramen in the sagittal plane. Then we go to a cadaver section where we will see the same thing again, and you will find that the red outline or the red dots are showing you the lower part of the foramen. The upper part with the G is the ganglion. The LF is the ligamentum flavum. Now please note this, the ligamentum flavum is also present in the roof of the upper part of the foramen. This is the body of L4, lower is the body and the pedicle of L5. This is the transverse process, the TP, and G is the nerve. And this red outline is the lower part of the foramen where we commonly land when we do our transforaminal endoscopic surgery. Now, this is another picture which is a sagittal section where you see in a CT or an MRI, this is the disc. Then this black arrow is showing the inferior foraminal ligaments. This is the SAP. This is the IAP. This is the nerve. And if you see this arrow, this is the artery. Okay, this part is the artery, which is anterior to this area. This is the artery. Now we go further. This is a very important image, and I want all of you to please remember these dimensions. I'm just pointing out for L4 and L5. For L4, you will find that the distance between the pedicle is about 2.56 centimeters, that is 25 millimeters. And we commonly in our surgery access half of it, which is about 12 to 13 millimeters. That is, we access from the medial pedicle line to the midline distance, which is about 12 to 13 millimeters at this level. If you go down, this distance between the pedicles is 3.03. So this distance would be about 15 millimeters. And if you want to measure the distance from the lateral pedicle line to the lateral pedicle line, in the L4 it is about 4.7, and in the L5 it is about 5.2. So now we go to the next picture. Now here what I'm trying to show you is again the sagittal picture where now we have gone deeper in the cadaver. This is the midline. You can see the dural sac. You can see the L4 root which is coming out. I'm sorry, this is the L5 root which is coming out. This is the L4-5 disc. This is the L5 exiting nerve. This is the traversing nerve which comes out S1. This is the L4-5 disc. This is the pedicle of L5. The lower down is the pedicle of S1. And we are now more interested in this zone, this area. Now here I would like to point out to you something very simple, that during embryological studies we have understood that the nerve or the neural axis develops first, and the vertebral bodies and the discs, they develop later on, they develop around the nerve. Now here all of us know that if we draw a line on this upper end plate of S1, if we draw a line around the traversing nerve, and then if we draw the line on the inner border of the exiting nerve, we are actually drawing the Cambine's triangle. The upper part of the Cambine's triangle, as you know, is the vertebral body. This is body of L5. And just give me a moment. So this we have seen, this is a sagittal, this is a coronal view of the canal where we have understood the Cambine's triangle. We have seen the pedicle, we have seen the other pedicle. Now, please remember that we are looking at the floor and we have already removed the roof here. Then we go next. We see a MRI in the coronal plane, and you will find the same picture. For example, this is the nerve which is coming out, being shown by my cursor. This is the traversing nerve, and this is coming out from the uh, foramen below. This is the pedicle. This is the lower pedicle, and then this is the cambium strangle. Now, I would like you now to concentrate on this point, which I'm showing with my cursor. This point is the lower part of the foramen, just above the pedicle or inside the pedicle, where the traversing nerve is coming out. Please understand this point. And we will be talking more and more about this point as the time passes. Then we go to this slide, which I picked up from this paper by Kobayashi, who is talking about pathophysiology of lumbar canal stenosis. And the point which the paper is making is very simple. You have a proximal radicular artery, and you have a distal radicular artery and the radicular veins. And then we have a zone which is called as a watershed zone. Now, there are a lot of things which happen in this area in the form of hypoxia because of arterial compression and venous congestion and give rise to the symptoms, to put it very simply. Now, this study basically is in a dog. This is not a human representation, but this more or less applies to the human anatomy and physiology more or less in the same way. Now, I showed you a diagram before. I'll go back to that and I will bring to your attention what I have shown you is this thing in the upper part of the foramen, which is an artery, which is a branch of the segmental artery. And this is what gives the radicular artery, etc. We are again going to look at this in next few slides. So we have come to this slide about pathophysiology, and I would suggest that all of you can read this paper. This is in the World Orthopedic Journal, WOZ, and you can search on this name, Kobayashi, Pathophysiology of Lumbar Canal Stenosis. Unfortunately, this is the only paper which talks about pathophysiology of lumbar canal stenosis. Now, I'm trying to point out to you a new area where I'm holding a model, a plastic model in my hand, and I've drawn a red circle on the left side, and this is the lower part of the foramen. Now, if you see this facet joint, we are at the tip of the inferior articular process, and we are looking at the facet plane. And if you look down inside the canal, you will find you're looking at the lower border of the disc, you're looking at the upper part of the body, here you're looking at the upper part of the lamina, and we are actually on the shoulder of the traversing nerve, which now is becoming the exiting nerve. Now, this is a very important area. I'll talk about it very soon. Just listen what I'm saying. So in general, when we talk about lumbar canal stenosis, in general, what we have to remember is there could be changes of hypertrophy here, or the changes of disc where you lose the concavity of the disc, or you may have a small disc herniation, etc. Please remember that this portion of ligamentum flavum, which lies here dorsal to the dural sac, does not cause any symptoms whatsoever. Now, regarding this statement, you may feel that this is a very crazy statement. So I'm going to give you some more information. Now, traditionally, we have been looking at these pictures and these sort of classifications. Now, there is some cheating going on in this classification. What you have to remember is when you look at the first picture, that is grade A, you're looking at a full size dural sac, and you're looking at the posterior elements, which are more in the form of this inferior articular process and the lamina, and you don't see much of superior articular process. Now, this is a view in the upper part of the foramen. Whereas if you go to grade C or grade D, this actually is a view of the lower part of the foramen, and the cheating is very clear here, where you see the left image in the upper part of the foramen, where you see beautiful part which is subpars, upper part of the foramen on the left, and on the right you are made to believe as if this canal is so bad that you are unable to even visualize what must be happening here. Now, I do not agree that this left image and the right image is taken in the same plane. They are definitely not taken in the same plane. And now I'm going to talk about the ligamentum flavum in particular and these planes which I'm trying to explain. Now, this is the first plane which we need to understand, which is the upper part of the foramen. Here you will see that you are below the pars. The superior articular process is not much seen because we are above the tip of the superior articular process, and this zone contains the dorsal root ganglion and the root which is going out. This can be seen in this image, then this plastic model, where you have the exiting nerve below this pars or the inferior articular process. Now see here, this root is going out, this root is going out, and the dorsal root ganglion is seen very well. And we are looking at this upper part of the foramen. Theoretically, we are looking at this upper part of the foramen. Let me go back and highlight that point. We are looking at the upper part of the foramen. Then, this is an important slide which I have shown you last time, that this is ligamentum flavum, which is arising from the midline and going to the upper pedicle. If you see this blue arrow is a part where all of us have been made to feel that the ligamentum flavum is only from the midline up to this blue arrow. The part of ligamentum flavum which is above this blue arrow up to the pedicle is not shown, not seen, not talked about, and nobody knows about it. Most of the people ignore this part of ligamentum flavum, which actually is forming the roof of the upper part of the foramen. Again, I will repeat, it is a part of ligamentum flavum which is here, or you can say which is here, which is coming from the midline towards the upper pedicle, and it forms the roof of the upper foramen. Again, I'm repeating, if you see the left image, this is a plane and the things above this. Now this plane is actually a line which is at the lower end plate, and this is a line which touches the superior articular process tip. So everything above this plane, or here you can again see everything above this plane, is the upper part of the foramen, where you do not have ligamentum flavum in the midline, but you have ligamentum flavum below the facet coming up to the pedicle here, and it forms the roof of the foramen in the upper part. Now here I'm showing the same thing in a coronal plane, where this is the plane drawn here. So above this is the upper part of the foramen, below this is going to be middle part of the foramen, and then the lower part of the foramen. So here is the middle part of the foramen, or the foramen which is in the plane of the disc. Now this is what we commonly see. Just give me a moment. Okay, so this is the common view which we see when we are doing a transforaminal endoscopic surgery for the disc. And here we land and we try to remain medial up to the medial pedicle line, and we work in the foramen. We enter the disc here, we go right up to the center, we work under the annulus, etc. Then in this plane, what is lying in the front is the annulus and the disc, and at the back in the foramen you have the facet joint, capsule, and the ligamentum flavum. Now, please pay attention very carefully. The ligamentum flavum is seen like this. If you see the images on the right, that is the cross sections, you will find that the ligamentum flavum is this. That is type A, which presents from the midline up to the facet joint or up to the medial border of the pedicle in a coronal image. The type B is the one which undercovers or which covers the undersurface of the facet, and the type C is the one which comes right up to the pedicle, or in the cross section you will see it covers the whole of the facet joint. This upper part in fact continues outside the foramen as the intertransverse ligament. Just give me a moment. Somebody is finding it difficult to join, so I'm just trying to advise him how to log in. Okay, I'll repeat. This is an image which is a very important image. The blue is the ligamentum flavum. It has got these three types as is understood in a common routine patient. And this blue shows that this is type A, this is type B, this is type C. The type C is basically the one which goes right up to the pedicle and forms the roof of the foramen. Please be clear on this point. We are not dealing with type A only. We are dealing with type A, type B, type C. Now, how do we know beforehand? We need to study the images much better than what we do. Now, here, there is some issue here. Just give me a moment here. Okay. Now, here is a picture of the upper part of the foramen at the level of L2-3. I'm sure that you're able to appreciate what I'm saying. What I'm saying is, what's happening? What I'm saying is, I'm trying to show you the upper part of the foramen, which is above this lower pedicle line and the tip of the SAP, everything which lies in this upper part of the foramen. So here you will see on the left side image, the pedicle of L2, and the image on the right is just below the pedicle. How do I know? That just below the pedicle in the right side image, you will see that G is the dorsal root ganglion. And this IVP is all the venous plexus, intervertebral or intraforaminal venous plexus. Then you will see this is cauda equina. You will see the ventral root and the dorsal root. And what you see here is the artery, is the segmental artery. And you will see that this blue thing is the ligamentum flavum, which is already mixed up with this facet capsule where you have that star. So what we are looking at is the upper part of the foramen just at the level of the pedicle above and just below the level of the pedicle. I hope this is very clear, and it is also clear to you that the ligamentum flavum is coming right in the roof of the foramen in the upper part of the foramen. Now this is again the same thing in a cadaver where now we are showing at L4-5. I'll clarify what I'm showing. The upper picture, if you see, you have the body of L4 and you see this G. This G is the dorsal root ganglion. This is the pedicle and we are just below the pedicle. And this DA and LA are the arteries, the digital artery, and this is the sort of lumbar segmental artery. This is the ventral root. This is the dorsal root ganglion. This is the superior articular process in the inferior part of the image. The inferior articular process, the DS is the dural sac, and this is the foramen. And up here you will find that you will have the artery, you will have the ventral root, you will have the dorsal root. This is a radicular artery. I'm sure you can see this black shadow or a dark brown shadow. Now this is all important. What is the importance here is when you have a hypertrophy of the ligamentum flavum in this upper part of the foramen, these arteries, even this PIA and the RA, these arteries get compressed and you have an issue with the dorsal root ganglion and the digital or the arterial supply to the root, and you have certain issues which come out in the form of claudication. Now we go next. Now here we are going in the upper part of the foramen in a CT, and you see this is a part of the foramen as pointed out by the various arrows, and this is just below this. Now this is the second image which you see on the right, is the one which we see commonly for our surgery, where we come in the foramen, we are in the plane of the disc. So till now, I have shown you the upper part of the foramen. I have told you that the roof of the foramen is formed by the ligamentum flavum. I have also shown you the relation of the ligamentum flavum with the artery at that level and the radicular artery. I'm just going to point out the artery again. Please see this. In the upper image, you will see this is the radicular artery here, and this is G is the dorsal root ganglion. So please remember, these arteries undergo compression and give rise to claudication, and there is a distinct role played by the ligamentum flavum here, which is adding to the compression. Now, we go to the second part, or the lower part and the lowest part of the foramen. On the left is the lower part of the foramen, where you will find that we are now seeing more of SAP, and in the lowest part we actually see more of or less of IAP, and then we see the lamina here. So note here that the IAP is seen less on the left image, and the lower image you see the lower pedicle. So this is the lower and the lowest. And I'm going to show some more images as to emphasize this. Now this is a plastic model where this red circle is being shown, where you have this upper edge of the lower lamina, you have this, the SAP, and the IAP will come and end here, and you will have this area, which is the lower part, and then below this will be the lowest part. Or you can always call this as lateral recess, as we have been calling traditionally. So this is a plastic model to highlight that. This is another view of this lower part. See this here. So lower and the lowest part, which is on the shoulder of the traversing root becoming the exiting root. Now these are slides we show you in the L2-3. This is the lower part on the left and the lowest part on the right. Now you can see these are some transforaminal annular fibers. This is intervertebral or intra foraminal vessels, the veins. Then you have the dural sac. You have the spinal root here. This is the IAP. This is the SAP. The blue thing is the ligamentum flavum. And you will find as you go low down, the ligamentum flavum will recede. It will not be coming right up to the foramen or the roof of the foramen. And this is the way it is in the lower part of the foramen. Now this again is a cadaver section in the lower part and the lowest part. The upper part is L4-5. This is the body of L4. This is IAP. This is SAP. This is the spinal nerve root. And you will find this is a digital artery. And then you have the lowermost part. This is the pedicle. This is the disc here, posterolateral part. And now remember what I'm pointing out in the lower picture towards the tip of the IAP is the beginning of the lateral recess, where the traversing nerve will be becoming the exiting nerve. So this is an angle where a lot of things are changing. Now this is a CT picture of the lower part and the lowest part. So we have now correlated a plastic image, a cadaver section, a stained section, a thin stained section, and a CT section. And we have tried to understand that the lateral recess and the start of the lateral recess is very important. Now, what I'm showing now is entirely purely about ligamentum flavum, and please kindly see it very, very carefully. The upper image or the A image is showing you the true 3D structure of the ligamentum flavum. Now what it shows is the orange is the nerve and the pale green or yellow is the ligamentum flavum. On the right, the image B is where the bone has been removed, and you can see very, very clearly that the upper horn of the ligamentum flavum is going right up to the foraminal roof, right up to the upper pedicle, and it compresses the pedicle, it compresses the nerve there just below the pedicle. This is very important. In addition, of course, you can also concentrate here on the lower part of that ligamentum flavum, which is coming at the start of the lateral recess. But the amount of ligamentum flavum in the upper part and the amount of ligamentum flavum in the lower part are different. Now, what I'm showing you is something very important, and I can tell you that this is a paper which is only one of the 3 papers out of about 500 papers which I have searched, which talk only about ventral dissection. Now, what do we mean by ventral dissection? What we mean by ventral dissection is we go from the front. We remove, in a cadaver, we do a vertebrectomy, or we remove the corpectomy. We do a removal of the body of the vertebra. Then we remove, or we look at the dural sac, as you can see here in the right side image, and we are looking from the front. So what we see here, this is the dural sac. You can see the L5 root, which is labeled, and you can see the traversing nerve here, which is going down. And you can see this red circle, which is the lower part of the foramen, or the lowest part of the foramen, where there is a start of the lateral recess. And the LF is the ligamentum flavum, which will involve the nerves, one here, that is just on the inner border of the exiting nerve, and the second will be on the inner border of the inferior facet, this LF, okay, which is shown here. Now, please also look at this image again on the right, and you will find there are these labels in this horizontal line. The C is central, the S is subarticular, the F is foraminal, and the E is extraforaminal. You will find that the pure central zone has nothing to do with the stenosis. Now, this is another image from the same paper, which has been written by Okuda, and it is published in European Spine Journal. Those of you who want to go in for that, they can search for this paper. Now, this is a ventral dissection, and you can see very well how this ligamentum flavum is. It is here in the center. This is over the anterior aspect of the facet joint, and this is the roof of the foramen. In the lower image, we have shown the pedicle of L5, the pedicle of S1, and you see 2 perforated areas in the roof of the foramen in the ligamentum flavum. One is the dorsal root, which is going up in the lower portion, and the upper hole is the artery, which is there. So please remember that the upper part of the foramen will always have the artery, and it is extremely dangerous to go there. That is, you should never go cephalad to the dorsal root ganglion. Now, here is a very, very important slide, and I would like you to pay very proper attention, because this is the gist of my talk. This is what it is. This is the real secret of ligamentum flavum and the lumbar canal stenosis, and all that a transforaminal endoscopic surgeon can do. Now, what I'm trying to show you is I'm going to take this laser pointer so that I'm able to show you better. And I just want to know from you that you are able to see the laser pointer. Okay, are you able to see the laser pointer?
Yes.
Yeah, okay. Now, the first thing what I'll tell you is that I have marked all these zones with these blue lines which are horizontal. This first blue line, which I am now pointing out with the laser, is the blue line which is on the lower border of the upper pedicle. So let us say that we are dealing with L4-5, then this blue line is the lower border of L4 pedicle. Okay. The second blue line is the lower border of the body of the vertebra, the second blue line. So indirectly, between the first blue line and the second blue line is the upper part of the foramen, and this is where the exiting nerve is going out, correct? This is where it is. This is below the pedicle, and you will be surprised to see that almost always there is a groove below the pedicle on the medial border and the lower border of the pedicle. The second zone is between the lower border of the L4 and the upper border of L5. Now let me clarify again. This is a ventral dissection. We are looking from the front. We have removed the body of the vertebra and we have removed the dural sac, and we are just looking purely at this brownish ligamentum flavum and the posterior elements. Now this line is the upper border of L5. The second line was lower border of L4. The first line was lower border of the pedicle of L4. Now here you will find this orange zone is the disc or corresponding to the disc. Then between the third line and the fourth line. Now what is this fourth line? The fourth line is the one which bisects the pedicle. It bisects the pedicle like this all across. And why do we bisect it? Because this is also the lower border of the inferior articular process. In fact, you can see here, this is a part of that. And I'll explain this red circle within a minute. The fifth line is the lower border of the pedicle, or this fifth line is similar to the first line. Okay? So we are going from the lower border of L4 pedicle to lower border of L4 body to upper border of L5 body to the mid part or the cross bisecting line for the pedicle of L5, and then the lower border of L5 pedicle. Now in the upper part is the nerve in the upper part of the foramen here, and the roof is formed by this ligamentum flavum. You see there is so much of ligamentum flavum here. In the middle part, it is the ligamentum flavum covering the facet joint, and of course the changes of the disc which will cause the problem. But here I'm sure you can imagine that this portion, the midline, is it is not in the same plane like the facet. There's a depression here. This goes down. This goes more dorsal. In this third, that is the lower part of the foramen, you will see that the traverse. Now, please listen very carefully. I'm saying something very, very important. And I will just draw a line here so that you are able to appreciate what I'm saying. Now, this is a line which is the traversing nerve, correct? And this line now here will become the exiting nerve. Now this red circle is supposed to show you the area where the traversing nerve becomes the exiting nerve in the lower part and the lowermost part of the foramen, just inside the pedicle. And we are looking at the roof. This is the roof of the foramen in that part. This is something which is extremely important, and this is what causes the stenosis in the lower part of the foramen, this red circle. And in the upper part of the foramen, it is this blue circle where you have the exiting nerve, you have the ligamentum flavum, etc. Now, okay. So I hope this is all understood. I can always come back to this if you have any questions, and I'll just quickly now finish. There are a few more slides. Okay, now I'm showing you the same thing again. Yeah, anybody asking any question here?
This is Adam, sir. So you are talking that the ligamentum flavum offending in the foramen, it is in the upper and the lower part of the disc. I mean the.
I'm talking about it again. I will answer your questions after some time. Please listen so that we are more clear on it, and please mute yourself. Yeah. Now here again, I'm showing you number one is the midline in this picture, and you will see this whole brown thing which you see from this is all ligamentum flavum right up to here. It goes right up to here, mid pedicle or sometimes the lateral pedicle in some cases. And this ridge, as we call it, is where the facet joint is changing. That is, let me point it out now again. My cursor is showing the SAP, and then this is the central portion of the foramen. And as I showed you, the traversing nerve comes down and goes out like this. This red circle is the lower or the lowest part of the foramen where you have the stenosis, and the second part is here in the upper part of the foramen. I would say for sure that the upper part of the foramen would have the um, ligamentum flavum forming the roof, causing the compression of the artery and the nerve there. And in the lower or the lowermost part, it could be the ligamentum flavum and the bony part of the facet and the inferior articular process. Now we go to the next slide. Okay, so there is one more problem here, or one more change here, is that the facet commonly is at this angle 45 degrees. It is not necessarily so in all the patients. So the angle change, that is the facet being more vertical or more horizontal, will also make a difference to the compression. In the case of endoscopy, we put our cannula here and we take out this upper part, that is, we drill on the SAP. But let me tell you, this is not enough for stenosis, because the ligamentum flavum is still lying inside and it is lying more towards the lower part of the foramen. This is an old paper, but I would suggest that all of you please read this paper. This was published in 1997 by Saeed Usman and Dr. Cambin's group. And what they did was very simple. In a cadaver, they did a medial facetectomy as shown in the upper picture or the lower picture with this black area which was removed. And then they removed or undercut the facet. But please remember that they are only talking of the lower portion of the foramen. They are not talking about the upper portion of the foramen. But what they talked about is they felt that if you do a undercutting of the facet or a transforaminal decompression, you get about 45 to 47% clearance. And if you do a medial facetectomy, you get about 27 to 30% clearance of that stenotic area. So it is advisable to do a transforaminal decompression by undercutting the facet, by removal of the ligamentum flavum, etc., etc. Now, this is probably one of the last slides. I've just summarized everything. So please pay very, very proper attention. First of all, I'm going to talk about these vertical lines. There are 3 vertical lines here. The first vertical line is the medial pedicle line, which is joining the medial borders of the pedicle. The second vertical line, which I have labeled as important, is the yellow line, which is actually the medial border of the facet joint, or roughly a midpoint or a mid bisecting line between the medial pedicle line and the midline. So the yellow line sort of divides the distance between the medial pedicle line and the midline. And let me tell you that at the level of L5S1, this zone, that is between the medial pedicle line and the midline, is about 15 millimeters only. Now, we go to the horizontal lines, and the first horizontal line, as already talked, is the lower border of the pedicle. The second horizontal line is the lower border of the body. Between these two is the U, that is the upper part of the foramen, which houses the nerve as written on the right side, and the U is written on the left side of the image. Between the second line and the third line is the disc, which is the orange zone. The nerve zone is the blue zone. And below that is the zone between the lower border of the disc or the upper border of the body and the line bisecting the pedicle. And this together is the mid zone. So this is the disc zone, the orange one, the green is subfacet. And then in the lowermost part is the yellow zone, which is between the line bisecting the pedicle and the line at the lower border of the pedicle. So this yellow zone is all bony zone. Commonly, there is no change in the stenosis in this yellow zone. In the green zone, the change is at the tip of the IAP and the ligamentum flavum. The orange zone is the disc and the ligamentum flavum in the center between this yellow line and the midline, which is insignificant. It does not cause any problem whatsoever. The blue zone is the nerve zone or the upper part of the foramen, and this triangle roughly is the Cambine's triangle where we land in the foramen. So I'm summarizing. There are two more slides. This slide is we have a new system for tackling the lumbar canal stenosis. We have a better understanding of the soft tissue stenosis in the upper part of the foramen, the bony stenosis, additionally the ligamentous stenosis in the lower part of the foramen, and we have a new classification of lumbar canal stenosis. This has nothing to do with the older classification, older nomenclature, etc., etc. And I have shown you enough of structures in cadaver, in CT, in MRI. Then the last summary is in the upper part of the foramen for the soft tissue. I mentioned the other day that we use a cannon. This cannon is a RF cannon which can fire the soft tissue like a cannon. It puts out fire on that structure, can easily take out that. We use a flexible drill in the lower part of the foramen for the bony stenosis. And we will be introducing soon something which could be a transfacet surgery, etc. Very soon, all this contained in greater detail will be available on this link, stenosis.online. So this is what I had to say. Now I will go back. I will stop the sharing of the screen and you can ask me questions which you have. What I would suggest is better to ask it in the chat because we have around 70 people. So talking may be a problem, or you please follow a very decent way of talking one by one. But the best way is to put it on the chat. I can answer all of them. So whatever questions which you have, please ask me. And I'm sure that all your doubts about all this ligamentum flavum and all that nonsense which is talked about by the heavy metal group and by posterior midline axis and interlaminar over the top and all that, I have clarified in one single presentation. I'm sure that all these are very, very advanced concepts. We are already working on it. We have already worked on it. And there are various other things which will come to you very soon in the form of new instruments and new way of treating lumbar canal stenosis. So you can ask the questions now. Okay, Adam is saying that, do you mean that in endoscopic decompression, we should decompress the blue zone, orange zone, green zone only? No, I'm not saying that. I'm saying that you decompress the anterior causes which are related to the disc, which are related to the osteophyte formation on the end plate areas and the hardening of the annulus. In the lateral part, in the foramen, you take care of the tip of the SAP, the hypertrophic tissue, and the roof of the foramen where you have the ligamentum flavum. And in the lower part, you take care of the bony hypertrophy, or you take care of the soft tissue capsule cover of the facet joint in the lower part by going in the lower and the lowermost part. So the blue, the orange, and the green zone is for your understanding. And it is not to say that it should be done only there. I'm saying that these are the zones which you access in transforaminal surgery, which are better done by transforaminal access rather than posterior midline access. Now, somebody is saying in the upper part, somebody is saying open surgery, we are decompressing the same zone. Well, you can say that. I don't agree. You may say that you do the same zone. That is because the nomenclature is same. But in open surgery, you do not go in the upper part of the foramen. You just bluff. You put a catheter or a probe in the upper foramen and you say that, this is going, so the foramen is okay, it is good. You are bluffing, you are cheating yourself. I do not agree that you are doing the same. And in the lower part, you are only doing a medial facetectomy, which invariably, in many cases, results in breaking of the facet and instability. Then you justify that you do a fixation by putting transpedicular screws. But conceptually, I agree, because human anatomy is finite. I'm not inventing new anatomy. I'm just trying to educate you about the true structure of the ligamentum flavum, which has never been appreciated by the posterior midline surgery. We have never ever known the type 3 or type C ligamentum flavum. Now, upper part can address Cambian strangle. Dr. Sandeep is asking. You see, Cambian strangle essentially is a concept related to the floor. Okay, Cambian strangle is related to the floor. We are talking about the roof in the upper part. We are talking about the subpars where we remove the ligamentum flavum. Then transforaminal approach may hit exiting nerve. No, it never hits. I have done transforaminal surgery for last 20 years. It has never hit the nerve. It probably means that you're not able to visualize it properly. You can visualize it properly and you can then do the surgery properly. As Dr. Girish had said, upper as well as lower part of the foramen can be addressed through the Cambian strangle. But please remember, when you're talking of accessing it through the Cambian strangle, you're probably talking more about the floor. I am talking more about the roof. Then Dr. Vyapak is saying when we have to do bilateral decompression, we need to use both sides. Is it true or there is modification from unilateral? No, there is no modification from unilateral. You do biportal, but please remember that if you treat the patient well enough in time, only one side surgery and only one side access is enough. I need not tell you that when you're treating cervical radicular pain, you do a posterior foraminotomy. You don't really touch the disc in many cases. And what you find is you're able to see that the nerve comes back. Or when you do an anterior corpectomy or you do a posterior laminectomy in cervical spine, the whole dural sac shifts. Similar things happen in lumbar spine. And what we are saying is we are doing a lateral decompression. We are doing an anterior lateral posterior, that is a C type 180-degree one side decompression. So we expect the dural sac to move towards that side. But if the complaints on the second side also are severe, you can do biportal surgery. Then somebody is asking, will it help to position? Janmeja is saying, will it help to position the patient in extension, as it will help to cause the ligamentum flavum to bulge in the cannula, and or position doesn't help? The position does help, but you don't have to position the patient as a stationary person. What you can do is you can ask the patient to extend. Maybe you can give a pillow to the patient below the chest during that part of the surgery where you would like to tackle the bulging part of the ligamentum flavum. Now, what is the management in multi-level? In multi-level, I do the surgery at multiple levels, and because I'm doing the surgery under local anesthesia, I can do it many times, that is in various stages. I do it one stage at 4-5 and maybe second stage 5-1. But please remember, all this talk of multi-level stenosis is image-related talk. The commonest symptomatic stenosis is L4-5 and L5-S1. So commonly you can do both the levels at the same time on one side and maybe the second side if necessary. But there is no issue. You can do all the levels for that matter in different stages. What I mean by different stages is doing the surgery under local, the patient may have medical comorbidities. So you do say 4-5 and 5-1, then you go for the other levels. Okay. So the questions in the chat I have finished. Now, all those who want to unmute themselves and talk, they are welcome. Please ask your questions. We are open about it. I would like to ask one comment from Karthik. Dr. Karthik Kailash, what is your comment on what we just talked? Unmute yourself, please.
Well, I've been going on the. Let me get the microphone on so it's easier for us to hear.
No, I didn't get you. Please say it again.
I'm just getting the headphones on so it's easier to.
Your voice is resonating quite a lot. It's okay, but yeah.
Is that better now?
Yeah, perfect.
Okay. No, I come from the conventional old school